Hi, this is Gerald Major back with hashtag C Arthritis, reporting from the Canadian Rheumatology Association Allied Health Professionals Annual Meeting. I'm here with Dr. Sasha Bernatsky. And so basically, let's get into an introduction of who you are, what you do, and why you're here this week.
Okay, thank you. So Sasha Bernatsky, I'm a rheumatologist and a researcher at McGill. I'm a professor of medicine there. And some of the work I'm presenting at the ACR this weekend includes our work on biosimilars. We are actually funded through a joint collaboration between Health Canada and CIHR to look at a question posed by Health Canada, which was, what does a biosimilar used in Canada look like, and how do the outcomes of people who are on those drugs compare to the drugs that those less expensive biosimilars were meant to replace the original biologics. So that's some of the involvement that I have at the CRA this year.
Excellent. That's a very hot topic.
Yeah.
And that's also been covered. I mean, you probably follow the conversation at the ACR and EULAR.
EULAR, right.
So happy that you're involved in that, and thank you so much. I mean, there's patient impacts to that as well. So you also do a little bit of work in around comorbidities, and the reason that ends up being important to me, so the Canadian Spondylitis Association last year did a survey. We surveyed our membership, and in a lot of ways through my journey with ankylosing spondylitis and psoriatic arthritis is that I kind of know what to expect from them. It's all the other things that pop up. So of particular interest, and there was a definite difference between ankylosing spondylitis people that reported comorbidities and psoriatic arthritis that reported comorbidities. The big difference would be mental health. Mental health was number 2 after psoriasis in the PSA cohort, and pain was the number 1 from ankylosing spondylitis. So maybe talk about the impact of comorbidities and then zero in a little bit on mental health.
Sure. I'm happy to talk a little bit about you with that because it is so important. I guess one of the wonderful things about rheumatology is that we have drugs that can treat the inflammation and help people so that they're living longer. Some of these conditions, decades ago when we only had prednisone to treat the inflammation, unfortunately they were associated with relatively short lifespan. I think what we see now is that people are living longer. However, the flip side of that is that they're living longer to experience comorbidities.
Right.
So the older I get, today's my birthday.
Oh, happy
so
birthday.
I won't tell you how old I am, but the older I get, the more I sympathize with all the things that happen as you get just a bit older. When you have to deal with things like chronic pain on a daily basis, potential side effects from the drugs people might be taking. There's many ways that people with inflammatory conditions and rheumatic conditions can be at risk for comorbidity. And mental health is obviously so important because it also impacts how well you do in terms of that disease, in terms of the outcome.
Yeah, 100%. I mean, from a mental, and I battle mental health daily, and I speak about it quite a bit. And the thing about mental health that I've realized over time is that the answer to mental health ends up being, in a lot of times, good mental health. And that ends up being a struggle for a lot of people. So maybe speak about, the mental health aspects on chronic illness, because there's a slightly different path for those people than there are for standalone mental health issues, which I've been finding out lately through health psychologists. So maybe a little bit more perspective on, the mental health component of specifically around or attached to chronic illness.
Okay, well, I'll tell you what I know. I don't know if I'm an expert specifically in mental health, but it's an important part of what we do. And I think it's kind of interesting because the reason I went into medical school was because I wanted to be a psychiatrist, because I wanted to help people who had... But in the end, I fell in love with rheumatology. And it's interesting because in my clinic, I have a lupus clinic every week in Montreal, and some days I walk out and I say, 75% of the people that I saw today had a mental health issue.
Yeah.
So I guess no matter where you are, you have to think about mental health issues. What I found really interesting in the population that I serve is that you have people who sometimes are affected by these conditions when they're relatively young, reproductive age, or you're trying to be part of the workforce, and these conditions can be a bit cyclical. They can be, flaring and remission, and I think that almost unexpected nature of the course of the disease creates almost a feeling of anxiety because you don't know what to expect. So that's a bit of my hypothesis, and that's what I'm finding from the people I talk to. What I am so impressed with is the resilience of people. Right. It's just incredible, talking to people sometimes who've had these conditions since the time that they were 12 or even younger. It's incredible.
Yeah, I mean, and it's, mental health is a hot topic these days as far as, speaking about it, and there's lots of encouragement to do so. But then you end up with conversations with people that may not be the people or not professionals. So, I mean, there's a delicate balance, I think, with mental health these days. And the other thing that I notice quite a bit is that as a society, we seem to be recognizing mental health and talking about mental health. But when mental health actually happens and it doesn't look very good, I still feel that there's no tolerance for that. So from a patient perspective, I mean, anxiety you can't always control. You can't control what it looks like. Sometimes it looks irritable. Sometimes it looks aggressive. And I wish we would get a little bit further on that aspect of it, not just identifying it's there, but also remaining around when it's happening.
Well, obviously we have a long way to go, but it's interesting that we're having this discussion about anxiety because I think, in the 1950s or 60s, then nobody talked about depression. Right. But over time, in the 80s and 90s, it was okay to talk about depression. But I feel we need to kind of have that epiphany for anxiety because I see a lot of correlated depression and anxiety. Some people think it's almost the flip side, like depression is the flip side of anxiety, that they at least coexist. And you mentioned being irritable. So sometimes being depressed, you don't seem depressed, but you seem irritable, but yet it's a clinical condition of depression. And sometimes anxiety manifests as irritability. And it's unfortunate because it can happen that your support people, your caregivers, your family can get pushed away because they're kind of repulsed by this irritability. It's a really difficult situation. At the same time, we have to work towards open discussion with our family members and our patients, our care providers. You touched on something that's very near to my heart is the whole caregiver situation. So I have an 8-year-old daughter at home, hi Tessa, and my wife Anna. So I've seen over the years, I mean, I've had this disease since 14 years old, so you can imagine what my 20s and 30s look like, to your point. Symptoms in 1986 and no biologic therapy for me until 2005. So that was 19 years of living very poorly. So thanks for mentioning the caregiver aspect of it. But that's so important, especially when you talk about mental health and mental health impacts your family like that. So let's switch topics a little bit now and start to talk about what patient-centered means in your work. Well, I think that I have a changing understanding what patient-centered means. I still have patients who, I'll be discussing a therapy and I'll ask them what their opinion is, what their preference is, and they'll say, "You're the doctor." Right. So I at every encounter I try to get a sense of what my role should be to help that person. I think thinking about ways to make the information more accessible to that person, no matter where they're at. So they may be at that level where they just want me to make the decision, but I have to try to continue to involve them in that conversation.
So the patient groups that are attached to the Arthritis Alliance of Canada, there's 5 of us. And so do you see value in patient resources in this way and the advocacy that we do?
Yes. Oh my goodness, yes. So advocacy is essential, I think, in terms of speaking to the people who are making decisions, policymakers, people who are deciding how to spend healthcare dollars. It's interesting, but speaking as a physician doesn't have the same impact as somebody who speaks as a patient. It's really important for them to look into the eyes of someone and understand what they're dealing with.
And so in the patients that you see, so from a patient advocacy, really the stuff that I do well and I care about is actually having the conversations with patients. What have you learned over the years from the patient community, just with respect to, how well they're informed? To your point, are they making informed decisions? Because that's what we try to do as patient groups, is try to fill those gaps, either in support or education or awareness or policy. So what have you seen? Have you seen a transition of empowerment yet from patients, or is it still waiting to happen?
Well, I think, again, that conversation of that person who says, well, you're the doctor, you make the decision. There are still people who present that attitude. So in part, I think it's sometimes a person can feel overwhelmed that they do want somebody else to make the other decision for them. And you'd be surprised because it's not necessarily like the 80-year-old
right.
individual.
I was one of them. I was one of them for 20 years.
Yeah. So I think sometimes you have to involve the patient, but you have to also recognize when a person's feeling overwhelmed and being able to point to patient groups for information that's at their level, activities that are occurring within the region that they belong to. Those are the kind of things that I think can help. But I think so often of the people who have, they may be a single mom, dealing with the kids, trying to be there for them, trying to hold down a job. It can be really overwhelming.
Right. I mean, they start to call that disease distress and those kinds of terms, right? So.
And yet, I am so inspired by the people I see who are somehow doing it all.
Right. Do we have anything from online, Anita?
Some patients, there's a patient asking for just some general lifestyle tips that can help patients living with chronic pain.
Sure. So what I like to recommend is, exploring exercise in whatever form a person is comfortable with. So if that's yoga or walking, anything that helps them, maintain an optimal body weight and feel good and be able to sleep, because all these things are so important, being able to have good sleep, feel good about yourself and have energy. So those things, that's something I talk about with my patients. Another is, of course, diet, and eating healthy is so important. It's interesting because there have been studies showing that different dietary interventions can actually play a role. So flax, for example, in people with lupus, some forms of lupus. So if people in my clinic ask me, I say, hey, take a look at flax seeds. Yeah, try to incorporate that in your diet. It's got all those omegas, and there's lots of health benefits. Fish oil, eating more fish in your diet, just following one of those, many of those elements of a healthy diet, I think, is also important. And stopping smoking. So that's, we talked about mental health. Anxiety and depression can somehow make it harder to stop smoking if you're a smoker. So I think that we need to think about all those aspects as we encourage people to stop smoking. But stopping smoking will help hopefully limit some of the comorbidity that arises. And in fact, sometimes smoking even interferes with the drugs that you take and makes them less effective. So these are all reasons to help people move towards non-smoking.
And when you mention optimal weight, is that different for everyone? So each person should talk to their doctor about that, or is there a general guideline?
Well, there are ranges, right? Healthy ranges. I think what we want to avoid, obviously, are people who we wouldn't want people to on one hand kind of have the kind of diet and sedentary lifestyle that causes your weight to be over what's optimal. But then again, you don't want people to be crash dieting or following a diet that doesn't really supplement or support a good, healthy existence. So in part, I think it's eating what makes you feel good, which will hopefully, if we were in tune with our bodies and ate what our bodies need, I think we'd have less trouble maintaining optimal body weight.
Well, anyone with chronic illness really, no matter what it is, can benefit from diet and exercise.
Mm-hmm.
For me personally, because I have the chronic fatigue, the pain, and the appetite issues, for me, I almost have to start with the exercise so that I can. So I'll run exercise basically on empty, to then get the appetite that I need to start to nourish, and then once I get the food going, then the exercise gets better, and once I get the exercise better, the fatigue is less and the pain is less. I mean, we can't underestimate really the value in exercise and nutrition and treatment. No longer we talk about certain medications being game changers, and I would argue that yes, they are. They're potential game changers, but if your base of your body needs to be moving, your joints need to be moving, your circulation needs to happen. I mean, just overall, you want to be feeling better in this disease. So, so I value your input on that aspect as well.
Thank you.
So is that it? Are we going to sign off? Okay, well, thank you so much for your time. Really appreciate it, and nice getting to know you.
Yeah,
Thank
great.
you.
Thank you.